So, good morning, everybody. I am Dr. Pasya. I'm the founder of LetsTalk-USMLE, along with the amazing team that I have here, Shanti, Ritvika, and a couple of others who are unable to join today. Uh, so the whole idea about LetsTalk-USMLE is getting the future applicants all the real information, the true, genuine information that we can't find sometimes on the internet. When you try to search around, you always get information from a lot of private companies which can be misleading. So the whole idea is to get you all the real practical information that would be beneficial and help you in this USMLE journey. As part of that, we are doing these webinars once every 2 weeks, once every week, trying to deal with the topics that would be beneficial to the applicants. So as part of that, we are doing a webinar today talking about the nuances of family medicine. How is it different from internal medicine? Is it like all the things you should know about family medicine? So I'm excited. We are all excited to have Dr. Denduluri as our guest speaker today. So we're calling her Amrutha. Amrutha Denduluri is a family medicine resident, currently a PGY3 at University of Arkansas Medical Sciences. And she has also completed her MPH at Harvard Medical School and before starting her residency. So we are excited to have you here. And before we get to Dr. Denduluri, there's one other person I would like to introduce. Dr. Vineet. That's what I would call him, but he can introduce himself with the full name. So Vineet is a recent graduate from Andhra Medical College from India, and he recently matched into family medicine residency at Ascension Health. So we are excited to have Dr. Vineet here as well. And we have our amazing team, Shanti and Ritvika, who are applying this year to match cycle. So I'm sure they'll be guest speakers next year with some amazing stories as well. So this is our team for today, and I'll pass on my speaker to Vineet first so that he can introduce, and later Dr. Denduluri, who can start the presentation.
Hello, everyone. This is Vineet Dasari. I matched to family medicine this cycle at Ascension St. Vincent Hospital, Indianapolis. So it's going to be all exciting getting into the residency and how everything works and getting to know everything from Dr. Denduluri. The how to navigate through the residency would be a great thing. So welcome all.
Thank you. And Dr. Denduluri, if you can take it from here.
Yes. Thank you so much, everyone, for organizing this webinar. I'm really excited, and thank you for reaching out. It's such a pleasure to be here today. My name is Amrutha Denduluri, and I did my MBBS at Usmania Medical College. And after that, I did a few clerkships, did a year of research in the US. The clerkships were all over the place, Cornell, Stanford, and I did my MPH at Harvard Chan School of Public Health in biostatistics and epidemiology before applying for the match. And after I did a little bit of structured learning in the public health degree and everything, family medicine seemed like basically a natural choice for residency because of the scope of practice. And I applied into family medicine, and currently I am a third year resident at University of Arkansas for Medical Sciences. It is in Little Rock, which is in Arkansas. It's like the Midwest, a little bit on the south side in the US, and currently transitioning and completing residency at the moment, and will be done in fall this year. So that's a little bit about me. Very, very excited to be here. And just to start the talk, I will be sharing my screen with a little bit of a presentation, and I was told that there'll be like discussion and questions after. Feel free to ask any questions, and I'll answer them to the best of my abilities. So that's that. Um, hmm.
Okay.
So I'm having this. Okay, actually, looks like I have sharing issues at the moment.
Okay.
Mm, it says only meeting organizers and presenters can share. I thought I was one of those.
Just a second. Do you see anything now? Sorry
Yes,
about
I
that.
do.
Okay.
Okay. All right. All right. I am sharing. Okay, everybody can see the screen and hear me and everything.
Yes.
Perfect. Perfect. Moving on. So this is my attempt to like give a brief overview. Obviously, in my opinion, family medicine is like a much larger conversation, and everybody needs family medicine doctors everywhere in the whole world. So there's basically a perpetual need for it. But I'll just try my best to like consolidate a little bit of information about the match process and what family medicine looks like in the US. Um, Disclosures, I work at UAMS. Maybe some of the information might be coming from the experiences through that. I love mangoes. Uh, so most of the content here is personal experiences. Some of it is from AAFP website, which is the American Academy of Family Practice, and the NRMP website, which shares the match data every year with very, very comprehensive answers for most of the questions that we might have. So I'd encourage everybody to look at both of these websites for information on FM. All right, so this is kind of an overview of what I have. What is family medicine and what does residency look like, types of programs, how to choose programs, what career options do we have, and networking and resources for folks who are outside of the US and need to connect because seeing is believing. And if you connect sooner than later, have a longitudinal relationship with family medicine docs or programs here, things get much, much easier when you apply. Everybody knows this, I believe. Just wanted to briefly give a definition, though. It is family medicine is a specialty which provides a comprehensive continuing healthcare for individual and the family. And the breadth is integrating biological, clinical, behavioral, psychosocial components of anybody's health, and the scope encompasses everybody, all ages, all genders, each organ system, and every disease. It's kind of overwhelming, but that is the reality. And most of the time, in different parts of the US and obviously in different parts of the world and India as well, there is scarcity of physicians in different rural areas or semi-urban areas, and family medicine doctors are generally the only ones available to give care, and that is true in the US as well. So you can actually make it as broad as you want or as narrow as you want as you go through your career. You can jump between different things and you can go back and forth. It's just like it's extremely flexible. And I mean, it's such a privilege, right, to be able to do this for everybody. So, regardless of what they have, you have a relationship with them, you have continuity of care with them, you take care of them throughout their life. You see different generations of family. And ideally speaking, a family doctor, a general practice doctor, somebody who's in the community is in contact with the community, who knows what the problems are in that community. Because when it comes to public health and social determinants, determinants of health, and population health. The local factors determine most of the disease processes and how they manifest over time, and what would be the most appropriate treatment plan for those folks. And it would family medicine doctors have a unique opportunity to like cater to that kind of like tailored medicine for most people. So just a little bit of a fact. I know this slide is kind of busy. I just wanted to like put it out there. So according to the 2024 match results, the match highlights, there are about 5,231 positions in family medicine in the US, the residency positions. And this is a little bit more than what we had in 2023. And this kind of encompasses about 13.6% of all the residency positions. And in those, actually, only 4,595 students and graduates matched. So as you can see, there are a lot of open positions. And that is an opportunity. And the other thing I wanted to point out is, can you see my cursor? No, not really. Okay, that's okay. So other thing I wanted to point out is that about 562 foreign medical graduates were able to match in the 2024 match, which is a significant number if you ask me. And that kind of encompasses about 15, like 13.5% of the total match in the family medicine. If you see the right-hand side, the closer look at the 2024 match results, roughly, I'm just breaking it down approximately. So 30% are US seniors, 28% are US DO seniors, 30% are MDs, and about 30% are international medical graduates. Among them, some of them are US citizen IMGs who go to like different medical colleges outside of US, which are like Caribbean medical schools or Indian medical schools or different parts of the world, which is like 15%. And actually, the same amount is non-US citizen IMGs. So they would match equally the US citizen IMGs and non-US citizen IMGs. If you look at the match results, like the percentage was almost equal. So there's a lot of scope here in terms of what, if you're looking into family medicine as a practice for application. And when you compare these results with 2023, 12% of foreign IMGs were able to get into family medicine. And that is about a percentage higher than 2023. So only 11.2% were foreign IMGs in 2023, and now it's like 12%. So obviously the demand is increasing. People are getting to know about this. This is getting more popular, and looks like we are also able to like competitively match with the other medical graduates from the US or US IMGs. There is still about 10% to 12% of the positions that haven't filled, which I wanted to point out as well. So just getting into FM programs, there are a lot of them. It's kind of overwhelming as well. Program sizes are a little bit different compared with internal medicine. So the sizes can be small, like 4 people, 3 people in each class, to like 12 people, 20 people in each class. So they range the range is very broad. And it also depends on if we were looking into a university-based program or a university-affiliated program, or if you were looking into a community-based program. And based on the location, the training breadth also varies. If you were in a community program or a program that is a little bit far from the university setting, there is, like theoretically speaking, and generally from my experiences, I've seen that the family medicine residents are able to get more hands-on experience on the, let's say, the obstetric care or delivering more babies or doing more, like surgical side of things, or being able to be the front line for emergency medicine in the rural setting and things like that. However, I'll go into a little bit of details as to what a university setting looks like, because that is one of, so my program is a university based program. So what's important for you? um, I know this kind of sounds very like futuristic in terms of, oh, I don't know, I want a good training sort of thing. But I would encourage everybody to think more carefully and deeply about what your priorities are, in terms of practicing medicine, short-term goals, long-term goals. What kind of flexibility do you want? Work-life balance do you want? What geographical location you want to be in? Even though those might not be the first things that come to an international medical graduate's mind, I've been there, and I did not think about these things back then, but just in retrospect, this would help with choosing a specialty, and not only choosing a specialty, but also applying to the right programs. So collect that information, both objective information and subjective information. Talk to more people in the specialty. Talk to people who have done this before, or other colleagues or mentors. Try to come up with pros and cons for each of these priorities. And yeah, and you can also look at the AAFP website for some resources on it. Oh, we talked about this before, but types of FM programs, like I said, there's university affiliated, community based, opposed, unopposed, where like some of the other residents can rotate through your program. When I say other residents, other departments, internal medicine or psychiatry or other people can share your resources or not. So that's unopposed, opposed. So if they don't share your resources, opposed. If they share it, it's unopposed. So we basically, our program, for example, we rotate through all these different departments: internal medicine, OBGYN, psychiatry, pediatrics, surgery, dermatology, ENT, ophthalmology. So we rotate through other departments, but we don't have other department residents coming to our clinic or our inpatient wards and things like that. So our program does not have that thing where other people come into the program for shared experience. We do have some transitional years so who come into the program, which is like when you apply for a match, if you just apply for 1 year instead of 3 years at a time, that could be a transitional year or preliminary year, where after that year you have to reapply, and they do rotate through our program. So combined programs, you could do FMEM, which is emergency medicine with family medicine. You could do preventive medicine with family medicine. You could also do psychiatry with family medicine. This is a little bit of a less number of spots for it, so there's a little complicated in terms of application, but it's possible if you find the right program. I have personally seen international medical graduates get accepted for some of these combination programs. So that's that. And coming to select components of training, so I don't I don't know. So I actually had to like look it up before I applied, because I did not know that the breadth of training was so much for family medicine. You get rotations, and basically you name it, you have it. So for internal medicine, you would do adult care, period. You would do you take care of adult patients. You will not see kids. You will not see gynecology or obstetric care. And generally, more times than not, you'll not see the behavioral health, unless you're like in a community setting where you're the PCP, or in like you're the PCP for patients who have a lot of behavioral health issues in the hospital or in the clinic. For us, we have outpatient clinics, which are continuity clinics, as well as urgent care. Urgent care would be just somebody would come in and you treat them for like something that's happening at the moment. That's not as higher acuity as an emergency medicine visit, but that's not like a clinic where somebody has a cut, somebody has like, you know, um, like hypertension, which is like uncontrolled. They just come to you, or there's a shortness of breath. And then you triage the situation. Sometimes you can send them home with meds. Sometimes you send them to the ED, and you can do this in the clinic. And this, you have that. You have continuity clinics where your patients keep coming back to you over and over for chronic conditions over a long period of time. You get to see them respond to medications. You get to see them go through life. You also get to like tweak things, change things, and rely on the fact that they will come back for follow-up, which happens more often times than we think. And community medicine is another thing that I think is great, because you get to know everything in the community. So we get training in that. And hospital medicine is actually a piece that a lot of people that I have encountered with did not know about for family medicine. You could basically get training in hospital medicine and inpatient services as you would in internal medicine. And some FM programs, such as mine, we have a dedicated family medicine inpatient service, which is staffed by the family medicine trained hospitalists who will be our attending physicians. And we'll have residents third year, second year, and first year, or based on the program, maybe a little bit less than that, one or two residents who would be doing inpatient work with family medicine doc. And you will get trained in basically all the inpatient conditions, patients with different things. And it would be like the hospitalist service or the inpatient service on a general medicine wards team. But since you'll have your own little service, you get all the experience that you need without a lot of competition in terms of, oh, will internal medicine come and take my procedures? Or will the other people from different departments get cases that I will not get exposure to? You will not have that kind of problems, because all the patients that you see in your clinic, if your hospital has the inpatient service, they will be automatically admitted to your wards, to your family medicine service, because you've seen them. They are a part of the family medicine clinic, like right away. Right away, excuse me. So you also get experience in research, in terms of like research methodology, how to conduct research, what kind of questions to ask, quality improvement projects, public health and population health related things, as well, if you want it. And health systems, learning about systems based practices where, you know, people can become chief medical officers in the future, or run different clinics, or learn managerial skills as to like what does it take for a hospital to function, and things like that. So that give you more, if you were to go into private practice, or if you were to like set up your own clinic, that'll give you more information as to how to do that. And there is curriculum for it, so that makes it easier, and it's much like nicer. And procedures, um, excuse me. On our inpatient side, we do all the procedures that anybody else would do: lumbar punctures, paracenteses, thoracentesis, and in the ICU rotations that we have, we do lines, CVLs, like umbilical artery and umbilical veins, lines and all sorts of things. And it's actually pretty nice because that'll give us more tools. We use POCUS, the point of care ultrasound, to do these procedures. And on the outpatient side, we do joint injections, we do true points, we insert IUDs, or any other like contraceptives that we could do. We could do colposcopies, we can do endometrial biopsies, um, we could remove different lesions from like skin lesions, excision of like different types of skin lesions, toenail removals. I mean, these are just a few of the many procedures that we can do in family medicine. And if you were interested in procedures, after you graduate, you can set up like a procedure clinic where one day a week or half day a week, based on where you go, you could do procedures. And you'd basically be also able to teach the residents or student learners in that particular environment if you're into procedures. OB is another thing that's like major benefit in family medicine. You get trained in doing deliveries, you get trained in doing different kinds of prenatal care, postpartum care, take care of the babies and moms during residency. And after residency, if you're interested, if you have enough experience, you could directly go into an OB-FM position, or you could also do an OB fellowship, which will give you a very focused training as to like how to do maternal care over a year, and you could basically do that for your job. So lack of so lack of better term, it's basically everything. So example curriculum, I thought it'd be neat to like add this in. This is the curriculum that I have from UAMS. It's been taken from them. So cardiology, geriatrics, internal medicine wards, our wards, labor and delivery, neurology, pediatrics, urology, surgery, airway, ICU, both NICU as well as MICU, emergency medicine, longitudinal clinics, electives. We have so many electives. We have like 6 months of electives, and you can make it into an elective track if you want. Like if you're interested in, say, sports medicine, you could do all the electives in like sports medicine affiliated specialties like orthopedics, procedures, and surgery. And you could so it there's physical medicine and rehabilitation and like things like that. So you can basically tweak your own schedule to make it whatever you want. This is another website with a little bit of curriculum. As you can see, it's like super wide. I just wanted to give you the breadth of what it is. And this is both exciting as well as extremely like intimidating in terms of you have to go into a new specialty every month for a new rotation, and you get to know them. This also talks about the people skills and how we build relationships and the interpersonal skills, how to run a team, how to be part of a team, what does the team need to get things done. And then you do it all over again after this month, in the next month. So it's very exciting. And you over time make friends and you go back to their longitudinal rotations, and the next year's like, hey, and then like you basically have friends from all specialties, which is pretty neat. We talked about this. Yes, application. Just moving on a little bit. I'm gonna be a little quick here in the interest of time. Application. What really any specialty wants or any program director is looking at, like being a part of looking into applications for incoming residents and being a part of the interview process itself, I can like say that uh, all programs are looking for people who are genuinely interested in doing this. And as much as you can show that in your application process, it's going to serve you really well. So you want to show that you're interested in the core of family medicine, in forming relationships with your patients, and that the breadth and the scope of family medicine excites you. And in the personal statements, they want to see specific instances that have inspired you to being here. And if you give specific examples, that's very easy to like relate to you, because like we are coming from another country where like most of us, if you're international medical graduates, I'm sorry, if you're like American medical graduates or from here, then you could obviously like get involved in the local fairs or meet the people. But people who can't meet these people, and if the virtual applications are still going on, the only way to like personally connect with an applicant is through your story. So try to be as genuine and sincere as possible in terms of your story, and people will receive it really well. And volunteer work can be anything, like the thought of you wanting to volunteer is great. So it can be any experience. And research wise, I think what everyone wants to see is that attitude of, if there's a problem or a scientific question, are you willing to look into it? Are you willing to work on it? And are you willing to get the skills to get get the research question answered? And this is so valuable. The curiosity and being able to do this is so valuable in clinical medicine, that any kind of research is valuable for an FM application. But if you do it in like family medicine specific things, that's great. But it doesn't have to be, because the good thing about family medicine is everything comes under family medicine, most likely than not. And flag the programs if you like them. You could do it for like 5P5 programs, I believe. And do not send letter of intent to all the programs. Just send it to the people who you really want to go to. And just learn that, like, if you're applying for, it's not wrong to apply for multiple specialties, but however, if there is a certain thing that interests you more than the other, just try to, like, when you apply, tailor the applications based on where you're applying, in terms of, oh, if it's internal medicine and you're applying for family medicine, let the letters show that you've basically are applying for family medicine. And if there were multiple instances where the applicant's letters say internal medicine and they're applying for family medicine, it's kind of disrespectful if you ask me. So try to keep an eye on all of those things. That should be fine. Careers after family medicine residency, like I said, can be anything you want. You could do fellowships, emergency medicine, palliative care, geriatrics, sports medicine, adolescent medicine, hospital medicine, OB, behavioral health. Um, yeah, those are a few that I can think of. And you can work in a hospital, you could do direct primary care, you could do a multi-specialty practice, you can work part-time and do whatever for the rest of the other time. Private practice and rural practice based on your priorities again. Um, so the things that I mean, this is just something you can look into later as well. So I just wanted to point out that um, so the average on average about 13.2% of people own their own practices after family medicine residency, and about 17% are part-time. And on family medicine career benchmark dashboard, you can find the different average salaries for family medicine docs in different parts of the US. So if that's something of interest, like obviously you want to look into all of those things, so you can go back and look into that, and look into work-life balance and burnout and everything. Just wanted to bring up that. So this is just an overview of resources that you can use to like support your journey. Go and look at these websites, read as much as you can, and get information. Information is power, basically. So guidance for international medical graduates is like a special section on strolling through match. That's a downloadable PDF. Look into that if you're interested. They'll give you strategies for successful match. They'll give you strategies for how to apply and compare programs. Yeah, this is just there is a interest group called FMIG Network. You can look into that if you want to like get an idea of what other people are doing for the match, family medicine. And anyone can go to the national conferences. And if you were applying for residency, I would particularly look into AAFP national conference. I believe it happens in Kansas every year, and it's a very valuable resource because when you go there you will basically practically meet hundreds of program directors and residents from each of these programs and coordinators, and introduce yourself, be confident, like go talk to them, sit at a table that like where you do not know anybody and just talk to them. And when you apply, they will they will have a better, they will have a better way of differentiating you and your application from the thousands of other applications that they get. So if you're able to, if there are, if you're in the US during the match process for clerkships or whatever, try to like go to these conferences. So that's my LinkedIn if you want to connect. And I was told that there is an Instagram takeover coming up. So I just put it on there. If you have more questions or if there's anything I can answer for you guys, I will leave it at that. And all right.
Awesome. Sorry about that. Wow, that was interesting and fascinating. Like I said, I had a lot of questions about how family medicine is different from internal medicine. So that explains in depth how is it different from internal medicine. I don't know if you guys realize there are different kinds of procedures like gyno procedures. You mentioned IUDs, contraceptives, skin biopsies, lesion biopsies, and all that. Those I don't think internal medicine are well trained. I mean, they can do it, but I think they're not well trained to do it once they start the practice. So that obviously makes family medicine above internal medicine, at least in the private part. So like I mentioned, the whole point is figuring out the differences between family medicine and internal medicine. I personally also like to talk about the salaries and the money involved after residency, because again we don't get good information on that. We only get like, okay, this is the average salary, but what exactly is the average? Like a person working in the VA center, they get like 190s and 190s, but there are people like for a PCP, but there are people doing the PCP in some remote area, they can get like 400 500k annually. So that's exactly what I always talk about, just to educate people. uh, so if I can ask a few questions, at least from the presentation.
Yes.
uh, so you the rural practice is very interesting. I've heard that people can also do things like colonoscopies, and is that something, is that true? Or at least in the rural areas when there's no gastroenterologist available.
So it kind of depends because you would need a little bit of training, but there are certifications available, and just talking to the right people in terms of getting those credentials will allow you to do more procedures than others. Sigmoidoscopies, anoscopies, like all of us can, I think, get trained in. Colonoscopy, since it's a little bit more invasive, I would imagine that there's a little bit more training involved, but I don't see why not.
Okay,
Mhm.
that's good to hear. Like I mentioned, if just for the people here, if you ever think of, like, for example, a person coming out of your medical school, and then you decide, okay, I'm done with doing all the fellowships, going one after the other, and I just want to do practice right after residency. If you are very clear on this question, the next question you should be thinking about is, would internal medicine is the right choice for me, or would it be family medicine? Because again, if you want to get into practice right after your internal, after your residency, think about a job where you can make a lot with whatever skills and credentials you have earned so far. That way you don't regret, okay, I've never done fellowship, and you don't want to feel that way. And thinking in that regards, I believe family medicine has a lot to offer. Like, you can do those minimal, small, procedures in your outpatient clinic, and you can, obviously, I don't know how, I don't think many people are, familiar with this, but Medicare and Medicaid is the big thing in US, and insurance companies, they are the ones to pay you at the end. And at the end of the day, you are the one to provide to your family. So think about a job where you can do a lot of procedures or a lot of interventions, or something called RVUs, where you can generate more money for whatever you are doing in a clinic. Obviously, patient care is that the most priority, but thinking about how much you get paid for whatever skill set you have developed over time, this is one thing you need to consider. If you want to do minimal procedures, earn more compared to just seeing patients, this is one thing you need to consider, like family medicine more than internal medicine. And I had I think I had another question about job searching after internal medicine. Do you think joining in a multi-practice group versus, I know academic medicine pays a little less, but multi-practice group versus just doing outpatient
Mm-hmm.
versus just doing inpatient, do you get to choose what you want, like just inpatient, just outpatient, like traditional practice, both? Can you get to choose that after your residency?
Absolutely. That's a great question. And that kind of ties up what you were saying before as well, like knowing your worth and actually getting compensated for what you know will also be helpful. And like when you're like looking for jobs, what do you want your practice to look like? And for example, I'm interested in teaching, and I want to be in an academic environment, in a setting where I have more learners in the environment, also colleagues who I can rely on, or have a supportive environment for me to grow as both a family physician, a teacher, as well as, to be able to like work with learners of different levels. So I applied for an academic physician job, and my job, just for example, has 30% of hospital medicine, 60% of outpatient continuity clinics, and 10% of mom and baby service. So it's basically really everything except for labor and delivery. So I could tailor it to that. Like you have to look for the right people, make connections, and talk to them, and know your priorities. I know another colleague of mine who's gotten to hospital medicine. So they're going to start their hospital medicine, 100% hospital medicine position next year. 7 days on, 7 days off, or 7 nights on, 7 nights off for the whole year. And they're getting paid like very competitively, and possibly the same as an internal medicine doc. And it kind of depends on what you can do, um, and what you want to do. So you could do a complete hospital medicine jobs. There are a lot of them, and that you can either do in a university-based setting, or a community setting, or a private hospital group, and they'll take you every day. Just as I mean, a lot of specialties get these, and all the specialties are great because doctors like have a role to play in every geographical location. However, like for me, if I have to say, I get a lot of emails, like people looking for doctors, like family doctors who can do different things, and like on a daily basis almost. So getting a job in a place that you want will not be a problem, and what you want to do will not be a problem. Um, and there are some other folks who are interested, who have done OB in India and came up here for residency, and they've done family medicine here. And they are confident enough to practice OB after residency. So they are looking for FMOB jobs where they would be in a setting where they'd be delivering babies. They'd be, some of them who are trained in like procedural OB, they'd also be doing C-sections. So it is um, it is actually scary but it is basically what you're comfortable with, and if you have the training for it, some people would get OB experience to do that, but you do not need a fellowship to do what you need to do. For the longest time, I was considering adolescent medicine fellowship, and I might do it in the future, to like tailor it to kids and young adults, because I really like that population. But during my residency, I've seen a lot of kids in the practice, a lot of young adults in the practice. I do feel comfortable actually catering to that population even without a fellowship. So I could just do that after, if I wanted to. So yeah, you can get hospital medicine positions, you can get only outpatient positions, and get very competitively compensated, because if you're one of those people who are like seeing patients really fast, and you get like every 10 or 15 minutes, if you see a patient, like you join a practice, you can basically see a lot of patients in the day. If that is you, uh, great, because there's a lot of demand for things like that, such as urgent care or being in a busy practice. And if you want low acuity, low volume, low acuity, high volume, high acuity, low volume, like based on all of these, you can kind of pick and choose your practice. There are a lot available.
Awesome.
And if you were to go into teaching, I would strongly recommend STFM, the Society for Teachers for Family Medicine. Looking into their website, they have a lot of resources for both residents, medical students and residents, and people who want to transition into faculty.
Wow, nice. Yeah, and also thanks for all the additional tips, recommendations on match application. That's a additional thing that we got today. So thanks for that. We can move on to Shanti has a few questions, I guess, and she'll be asking
Yeah,
this question.
I have a couple of questions from the Google form that we received yesterday. There was a question asking about should all the rotations be in FM for FM match, as I have rotations with outpatient clinics run by IM doctors.
The answer is no. The clerkships don't necessarily need to be FM, all of them, but it would be nice to like have like an overlap in the scope of practice, because if you were in an outpatient clinic, that is very relevant to family medicine, so you're fine. You should be able to use that for your clerkship. Put all of your clerkships, obviously, relevant or not. But if you want to tailor your application, you might want to have at least one or two experiences where they might have been a little bit of more, like they might give you a little bit more profound insight into what FM would look like. So clerkship in outpatient clinics, clerkship in hospital medicine, clerkship in internal medicine, pediatrics, clerkships in pediatrics, all of them would be fine. I mean, if you're, let's say, doing clerkship in neurosurgery, it might not be like that relevant in terms of a family medicine match, but you will still put it in your application, and that is still a US clinical experience. And the program, or the professor who writes a letter from the program, they can talk about your skills as a medical student, your curiosity, your interpersonal skills. Are you a team player? Are you easy to work with? Are you sincere? Do you come on time? Are you able to do the tasks? Are you able to take feedback? Are you learning? Did you make the best use of your time there? Because patient care, some of the aspects are similar in all the specialties, and some of the personal characteristics they look for are similar as well. So if you've got those, you can put it in. But I mean, if the letter says applying for family medicine, that would be better, because otherwise it would be kind of not great.
There's another question. It's not pertaining to FM match, but like match in general. A person has a question regarding LORs. They applied for match last year and they went unmatched, and they want to know if they can use the same LORs from last year with the same date for the upcoming match, or is it possible for them to ask the doctors to update their LORs?
I had the same problem, and I mean, I wanted to apply a year, but I had to delay it by another year for some reasons. And I actually went ahead and even though it was like kind of inconvenient for the professors, I went ahead and asked them I mean, they can say no. They can say no.
Yeah.
And if they say no, you just deal with what you have. Um, but most of them were receptive and understanding, kind of like give a one-liner explanation as to why this happened, not going into, personal details that are like inappropriate. So just give a good explanation and send an email. Um, you know, if they say yes, great, use the new one. If they say no, use the last year's date. That's fine.
Another question I guess most people have is like, how important is research experience to, do we need, is it fine to not have research experience at all?
Y- y- So it is, I mean, it is fine to not have it. Uh, but I would say if you have a chance, working on it will open certain arenas like for you, because research, like I said, is a process where like you're basically trying to be more curious about some of the questions, and you're taking it a little bit beyond like medicine, like written medicine, or like just the medicine that we studied and written the test, right? Like you're thinking beyond that. It's like, why is something a certain way, and is this the best way to do this, or does something cause something else? So that kind of shows the programs, or like in general, like for an applicant, that you're interested in improving the field of medicine. Not only just taking things for granted. Everybody doesn't have to be a researcher, everybody doesn't have to like produce papers or anything. It's not essential. And you could just be a clinician, and that's fine, it's totally fine. But just because of the competition that we have, and being an international medical student and everything, if you can find a field that is interesting to you, like I said, it doesn't have to be something very extremely specific. It can be something else. Like I could so we one could do research in like hematology oncology and still apply for family medicine and be fine with it. But the skills that you get from doing this research might put you in a different pile of applicants than they would have, because what they're looking for is, oh, are you able to think beyond what's given to you? Are you able to think beyond what people are telling you that this is best practice in medicine? But you don't need research to apply. Does that make sense?
Yeah,
Did I
that
answer the question?
makes
Yeah, yeah.
sense. So if I can add something to that, like I always tell people, okay, start thinking, working on your application retrospectively, meaning you download an application like the ERAS application that you're going to use for your math cycle, and fill out the things that you need to, like as if you're applying today, and see which all fields or parts that are vacant or you need to work on. And if the research section is something that is empty and you don't have anything, you're obviously missing on something for that application. And obviously it's getting more and more competitive these days, compared to last year. Every year it's getting more and more competitive. So I would personally recommend doing at least one, if not paper presentation, at least a poster, or talking something about, at least submitting the abstracts that would tell people that you are involved in the medical field, rather than just being academically enough. So like Dr. Denduluri mentioned, you don't have to be a clinician scientist or producing amazing papers, but just the bare minimum, like an abstract submissions or poster presentations, would definitely show your interest in that respective specialty you're applying to.
Just to add one more sentence on it, during residency, there are requirements for scholarly activity, and the programs might feel better knowing that you know how to do that. So that might be an additional thing. Like, just like, if you finish step 3, they would not have to worry about you not passing it. Just the same way as that, if you know how to do scholarly work or some kind of research, they know that, okay, that kind of requirement is taken care of, and they don't have to like put extra effort in you, and that kind of makes them want you a little bit more.
Yeah. Also, to continue on that, one other point is it is very important for the program directors as well, and they're always worrying about who they are going to take into the program because they are responsible for the resident they're taking into their program. So if something goes wrong with the program director is the one who is going to be blamed for taking that resident. So they also want people who can show that okay, they're going to pass their step 3, they're going to do well in their board exams, and they're going to at least be actively involved in research if not doing amazing papers, and they want a good clinician who would pass out of their program. So they also have that responsibility to take good physicians or good medical students. So if we can prove in every aspect like we are just there and we can just get through the residency without causing you any trouble, meaning you do your basic requirements like completing your step 3. If you can do that, they have one less thing to worry about. So, and again, doing one basic poster presentation, they'll think that okay, this person knows about things and I don't have to teach them in how to do it just to complete that requirement, as Dr. Denduluri mentioned. So tick all the boxes that you can before applying to your residency. That way your program director feels confident in taking you into the program. So yeah, I think that's something I want to add. uh,
I think we can take
I have a question.
from the audience. Yeah,
I have a question to ask. I think there's a general misconception that people apply to family medicine as a backup specialty. And what is your opinion on someone applying to, say, internal medicine and to FM as a backup? Do you think PDs would know when they look at a applicant's uh, CV that, okay, this person is actually applying as to our program as a backup, and obviously it's looked down upon? What is your take on that?
So again, I would go back to the priorities, right? So if you want to do certain things after residency, and both internal medicine and family medicine will get you there, um, I don't think there is any hard and fast rule that you can't apply to multiple specialties. Obviously, it does. I mean, if the program director or the somebody from the program gets to know that you've done this, it's going to be a little bit less appealing because obviously it's naturally speaking. But if you are able to tailor your application separately, you should be fine. And the same goes to letters, like I was saying, personal statement, like I was saying. uh, if the letters are saying internal medicine and you're applying for family medicine, that looks really odd. And I've personally seen that, like when we were looking at residency applications for like the future classes. And that's an immediate no, unless they've got like other credentials that are like extremely great, and they're like maybe because again we go back into what the motive is, what's the core value of this person is. Or do they just want to do they just want to take care of adult patients, and this is a genuine interest, but they did not like know how to tailor this application. And that's again nuances. And if the program director and the team, the committee, if they have the time to think about these things, great. But generally, there is no time to think about these things. So when they look at the application, certain things, and if things look like it's internal medicine and not FM, or pediatrics and not FM, kind of looks odd. But otherwise, if you're able to tailor it, it's fine. Because like I said, if you want to do the same things after residency, it's not you can't frown upon that.
okay. I think Krishna Saket has raised his hand.
Oh yes.
Yeah, I think he has a question. Do you want to unmute yourself and talk?
Yeah. Uh, Hi, ma'am. I just had one question. It's in relation to a point that you mentioned that people who have OB experience in India, IMGs who have OB experience in India might actually consider family would to OB like that. So I personally know a lot of our own assistant professors who've reached out to me to actually ask about the whole USMLE process because they're trying to look for it. And the data actually does suggest that family medicine has 59.7% acceptance as opposed to IM or something for non-US IMGs. So my question is, would you say something like family medicine uh, residency would be benefited from someone who's an OB postgraduate doing a course like MPH or something in the US? Would you see that something like that, a course like that, has any benefit? Because I understand that it's also a very expensive course. It's not like it's a
Yes, great questions. It looks like I'm going to take it in like two parts. The first one is yes, family medicine residency programs in the US would love people who would like to do OB after residency. And if you've already got OB experience in another country, you're already certified, you've been practicing there, you want to come do family medicine residency and then go into FMOB afterwards. That is where the direction of family medicine as an entire specialty is going, because in the US the number of people who can do OB who have been trained in family medicine has been declining with time, and in number of places there is no access to an OB. US is extremely like it's like in the vast setting of the country. A lot of places need OB, they don't have OB, and there are bad maternal and child outcomes because of it. And as a specialty, all of us are trying to improve OB experience. And if somebody wants to apply who has OB experience and would like to take that, carry it in the future, I think that would be the most appealing thing that the programs would look for. And I would suggest that these applicants should apply to the programs which are OB heavy. These programs are kind of different, and all programs are not OB heavy. They want to be in a program who would like to develop OB curriculum and do more OB, have OB fellowships, or like a community program which has more hands-on OB. So that would be more nuanced, but yes. The second question you've asked is, I'm sorry, what was the second question? I'm sorry.
does a course in a public
Oh, yes,
sim-
public health. Yes, yes, yes. So I actually personally got a scholarship to be able to do my MPH, and most of it was paid for. So when you apply for MPH, I mean, it's not necessary to do an MPH to get into residency or anything. It's actually like sometimes if the objectives are not clear and they're not building up on each other, it can be detrimental because you'd be a year out of your program. But having a second degree in a field that you like is helpful in building what you want to do in the future. So if that's your if population health, public health, global health, biostatistics, or things like that, there are like social determinants of, if you're interested in things like that, to get a network, to get a basic structural education and things like that, doing an MPH is useful. And there are a lot of scholarships available in most of the MPH universities, where either it's a partial scholarship, or if you can if there is like a need, there's like need based scholarship, there's merit based scholarships. And in your letters of intent for MPH, if you actually tell them what you want to do with your MPH, they will tag you to the right award. For example, in the letter of intent that I did for my MPH, I said I'm interested in maternal and child health, and I gave examples of what I did in the past because that's what I'm interested in even now. And they were able to tag me with a scholarship that was specifically given for maternal and child health in MPH. And that was nice because people would not have actually been able to do that if I did not put that in my letter of intent. So you might want to like make your goals and objectives clear. And most of the MPH programs do have a scholarship application. And if you get that, if you want that, if you want to get more training in public health, it's a great opportunity. And public health and family medicine kind of go hand in hand as well. So, and after that, you can work for, the State Department, Department of Health, Health and Human Services, the NIH or CDC. Like you can look into different ways to getting into these places if that's your goal.
uh, the USMLE steps course per se to get MPH, to do an MPH course? Is that right? As I understand, yeah.
Yeah, no need. I don't think they look at USMLE at all.
That's
to add.
interesting that you talked about MPH as well, because it's again one less explored area IMGs can consider if, like you mentioned, they are interested in one specific field, or that they want to work in the future. But I also wanted to add something that I recently heard, that some people take up MPH just because they have not given their steps, and they have this gap after graduation that they want to fill in. But I've heard from few people that doing MPH, if you're not really wanting to do something with that in the life after your residency, it's actually going to be detrimental. Because if you do MPH, like for example, take into the bigger scenario into picture, if you're doing MPH, you apply for all the programs, and there are certain community programs who will look at MPH degree and think, okay, this guy has done MPH, I and they think that this person would benefit going into a university program, because they don't know you as a person, but they obviously think, okay, this person has done MPH, they want to do something with their life after their residency, and the community program doesn't have resources to to incorporate whatever they want to do in their life after their residency with the MPH. So they would think he is not a good fit for their program, and they are losing on some community programs. I've heard this from few people. So do you think that's true, Dr. Denduluri?
So again, what MPH is the question? So MPH has like 10 or 15 different subfields in which you can major in. And if you're doing social determinants of health or population health and things like that, or um, something that can be done like in a community setting, then you're fine. But if you're doing something which would need I don't know, a clinical library, a medical school, a public health school, or a team of physicians who are doing clinical research after, then they would be like, oh, university might be a better place for them because they want to do this work. And we don't have that, like you said. For example, like even actually healthcare management, if you did like health systems or healthcare management, and if you want to lead that community hospital in the future, come up with a new, like I said, a private setting that's yours, you own the business, or you like want to run a non-profit, MPH is very, very useful because they will actually teach you like how you're able to do that and tailor your curriculum based on it. But if you're doing things which need very nuanced lab or things like that, or if you want to go into academia, if the community setting doesn't have learners, then that's going to be a problem. But if the community residency has learners and you want to just like teach and be a part of that community's hospital and residency, eventually take up leadership positions in the hospital, MPH is useful. But again, like I said, it's a case to case basis.
Yeah.
And if there is no interest, actually getting through the coursework is hard. This like takes up a year or 2 years of your time and energy, and financially, like you will have to like give some amount of money for like living expenses and sometimes tuition. This is a big commitment, and if the motives again are not right, then it might get
It's not.
really difficult.
Yeah, it
It's not
doesn't
worth
make
it.
sense. Yeah,
Yeah.
exactly. Thanks that we
But
talked about it.
one last thing is that if you're not doing anything for a year and you want to network and learn more about medicine, I would still suggest you do it if you have the like means and time and everything, because it opens up so many different things like that we do not know about. Like I personally um, had a lot of personal growth and development in terms of broadening my views, worldviews, meeting people from different diversities, like backgrounds and everything, learning from them. That's been very helpful for me. So if you're not doing anything and you don't have like other commitments, then you can go for it. um, or you can also go for it if you have specific interest.
Yeah, that
I had a
explains.
question. So how important are step scores for FM residency?
uh, I think step one right now is just pass or fail, right? So
Yeah.
that's you just pass that, and step 2 now we don't even have CS. So step 2 scores might be a little bit more valuable. However, like if you get average, national average, whatever that is, you should be fine. um, and if you get more scores, like the program directors might be like, oh wow, they've got 250 or 260, so um, we'll keep them in a different pile. However, the screening aspect of it depends on the program. My program does not screen based on scores. There are a lot of programs in the country that do not discard applications based on score cutoff. Um, they look at the whole application. But there are a lot of programs who do screen based on cutoff scores, and that would actually be on their websites, generally speaking. Or you can send an email to the coordinator, what their process looks like if you're really keen on that. Most of the information for this can be like when I was researching, like 3 years ago, I was able to find some of this information on their websites, but it's not that important. It's not everything. It'd be good to have it, but it's not everything. Like I personally did not have like super high scores or anything.
Is there anyone who wants to ask a question? You can unmute yourself. You can raise your hands also.
Maybe I'll ask a question.
Yeah.
So you were saying about few programs are heavy on OB and few are not.
Mm.
So in general, in a typical program, how heavy it is on gynecological procedures or OB procedures, and maybe in PGY 2 or 3, do we take them as an elective, or what if some people do not want to go
Yeah.
that path and do not want to do more of OB or gynec? Is there a possibility for that?
Yes, there is certain amount of basic requirements for family medicine residency that you will have to fulfill in OB, such as once in a while continuity, women's health clinics, prenatal care, and for example, um, 1 month of gynecology clinics or OB gynecology clinics in first year, and 1 month of inpatient labor and delivery unit in first year. And then in second year, you just do longitudinal clinics very sporadically. And in third year, you can basically choose your electives. You don't have to do OB, but there'll be like sporadic longitudinal clinics. So I would say 2 to 3 months out of 36 months would be OB at the minimum, and after that you can choose uh, what you want to do with it. There is OB call in certain programs where people will have OB pager with them, and if you saw the pregnant woman in the clinic and they come in for labor and delivery, you would actually be paged so you can go deliver the baby. So that would be a longitudinal thing over 3 years. So that's meant to improve your continuity of care, where you saw the pregnant woman before labor, you saw the pregnant woman during labor and delivered the baby, and you saw the pregnant woman like postpartum, and you also did a newborn visit for the baby. So, family medicine is pushing for continuity of care, but a lot of programs do not have OB call, so you won't have to worry about it. But there are certain programs that do have OB call, which might be something you will do during residency, doesn't have to be something you will do after residency. The same with pediatrics, actually. Pediatrics, inpatient, outpatient, pediatric ICU would be basic minimums, and then you would have longitudinal clinic in pediatric hospital or whatever pediatric clinic that you have in your program. Longitudinal clinics meaning you would have it like once today, once next week, once 2 weeks from now, and you sporadically they'd put you in that clinic, and that happens for 3 years. That way you can learn more, see more, because all clinics don't have a lot of kids coming to their clinic, so they put you in the pediatric hospital or the affiliated pediatric clinic to your hospital for it.
Yeah. Also, I mean, adding on that, like, how are the clinic days? Like you're saying, do we have like once in a week, or do we have OP blocks separately, or does
Mm-hmm.
it change from program to program?
So that changes, but the family medicine boards, the board, ABFM and AFP and all of that, the people who come up with rules, they said that you need 40 weeks of clinic a year, or 40 in 40 weeks you have to see at least clinic. You have to do at least one clinic per week. In 52 weeks kind of adds up. Sometimes it's a little less than that, sometimes a little more than that. If you're on inpatient rotations, one half day or one full day in the week, they will put you in the clinic to meet those requirements. So let's say you're in the MICU, Monday to Sunday, and you've let's say you have Sunday off. Friday they'll put you in the family medicine clinic, and Monday to Thursday and Saturday you will be at the ICU. So on inpatient rotations, you'll have arrangements like this to meet the requirements. But when you're on outpatient rotations, you basically have 5 days of clinic. And in that, if your clinic has urgent care, they might put you on some urgent care slots here and there in the week. And if your clinic has procedure clinic, they might put you on that because you'd be a resident. They want you to get trained in as many things as possible. So if it's a clinic month, you'll be on 5 days of clinic.
Okay. I
I
think
think
Pramod from the audience
yeah.
has a question. If you can unmute yourself, Pramod.
Um, good morning, ma'am.
Hello.
Uh, so thank you for organizing this session. And my question is, if we are applying for the dual specialties like both IM and FM, if our letter doesn't specify anything, like it just, provides information about how good we are in the clinics and all, and it doesn't specify like if you are applying to the IM or FM, will that be a good letter or will it be considered as something, a drawback?
That's okay. That's okay. And I mean, in the I would think that in the order of preference, one would prefer to have a specified specialty in the letter, and next it's like don't specify anything, and the next thing is apply to the wrong specialty. So what you're mentioning is like a middle ground. So that's fine. It's not a bad idea. However, it's not as specific as the letter that you would have where they would tell what specialty you're applying for. That's okay. And I guess the programs also care more about what's written inside of it. If it is like a letter which doesn't specify where you're going or what specialty you're going for. So as long as it's a good letter, I would say it's okay.
And also a different question. So if we applied for the previous match and we only applied for the IM, uh, will the FM programs this year raise a question that why didn't you apply for the FM last year or something?
No, they don't have, I don't know if they have access to that kind of information. And even if, I mean, they can't ask you questions like that, like where else have you applied, or who are you ranking. Like it's there's certain rules that kind of prohibit programs to like take negative action based on certain things. And if you don't put it out there, it's highly unlikely that it'll come up. It won't come up. And priorities
And
change, people change, what we want changes. It's not a crime.
uh, and also if we are applying for both IM and FM in the same program, like if we take, for example, Griffin, and we are applying for IM and FM in the same program, does it look bad?
I don't know what Griffin is, but in general, if you're applying for two specialties in the same hospital system, um, as long as they don't talk to each other, you're okay. But in some kind of environments where people are sitting in the same room and reviewing applications, and if it comes up, that's going to be a very tricky situation to get out of. So I would avoid it if you can. just because like if there's like a strong predilection to like one specialty than the other in a university or in a hospital system, just go for that. But if you really need to, that's okay. But I mean, you should be okay with the consequences as well, because there's no way to know, right? Like these things are very random. And when we think, oh, nobody's going to notice, maybe if they do, we don't know.
No, and last question, ma'am. Like, what is a good number of specialties? Good number of programs we need to apply during the match.
Well, that kind of depends on your overall application. If you think you're like you've got everything lined up, you're a strong applicant, you might be able to like tailor them down to a smaller number. But if not, if you're not tied down to any location and you're able to justify why you've applied there, because that question will come up every time somebody gives an interview or somebody looks at an application, they're on low. Why is this person applying to this place? What's their connection to this place? If you can't justify that in your application, in whatever subjective places that you have in your application, they might not be interested. So just thinking about pros and cons, and after a certain number, it can get detrimental to like apply. So just thinking about that, but having all your options open. So I want to know what other people think, because this is such a subjective thing based on application.
Yeah, that's a lot of interesting questions from Pramod, I would say. The first one is again applying to two different specialities in the same hospital. Like you mentioned, if they interact with each other and they know that you're applying to both, it wouldn't sound good. So being careful on that. It's again perspectives. If you still want to take the risk and do it, you can, but otherwise it's generally not recommended to do that. And talking about the number of programs, I believe Shanti and Ritvika are already thinking about how many to apply this year. But at least from internal medicine perspective, I believe they are applying somewhere between 150 to 300, if I'm correct.
250.
Okay.
200.
Yeah, I've known people applying somewhere between 150 and 350 programs, and depending on your financial situation and how much you want to invest. But at least, and it also depends on programs to program. For internal medicine, that's the numbers. At least for neurology, I've applied for 65 programs, and there are only like 160 programs, and most of them are university based. So, and I don't exactly have an idea about family medicine.
Yeah, there are a lot of programs, but personally I've only applied to like 30 of the family medicine programs, because the others did not meet the criteria that I was looking for, because I did not want to be like, in a place that like I'll be unhappy for like 3 years. But that's again perspective. So if you're applying for peds or internal medicine, or there might be more programs out there that meet your requirements. So you can apply to like much more, and family medicine you can apply to more as well. Like I think, if I believe there are about, I don't know, 300 or so programs, 300 to 500 programs available, but depends on where you want to go, what the structure of the program is, and you can apply to as many as you like.
Yeah, I'm just looking at the numbers. Looks like the family medicine, they have 790 programs.
Oh yeah.
So
So yeah, that's a lot. And the visa is another thing. A lot of people don't take residents who need a visa just because they don't have enough like HR staff or legal issues. Kind of nothing personal, but it really it's not great. But you just want to make sure that they are able to like support the visa process. If you want a visa, if you don't need a visa, then you have a little bit more open um, match process.
And also, if you're applying to a new program and we get an interview from there, how would we justify like we are interested in your program apart from the regional interest?
Regional interest and curriculum, they'll put out some things out there like what they want to do with the new residents and what their focus is. And if that's your focus, you can talk about their strong curriculum in a particular area. If they're going to give you overall like more comprehensive training, hands-on training without other people competing for different things in your training. You can talk about that. And you can also talk about being a part of a new program. You can, because that's a very different experience. You'll get a lot of attention. You might be able to like basically work with them in developing the program. And you might, if you're interested, stay back. You can talk about that. You can talk about, oh, I'm looking into, working with you on curriculum development, on making this program such a unique, experience, because you don't get to do this a lot. And learn from all the things that are like lessons that you can learn over time and improve the program. And then you can also say, like, stay back in the program. If you're interested in program leadership or being a faculty in the program, it might be easier in terms of, getting a job in a place that you already know all these people and they've seen you in time, like 3 years. So you should be, it's actually a great chance to like embed yourself into the system if it's a new system.
Yeah.
Thank you, sir, and thank you, ma'am, for answering my questions.
No problem. Thank you. Great
Thank you.
questions.
Krishna Saket.
I have a question. It might kind of be like a lateral way of question. So, uh, my question is that I know a lot of people who uh, their residency in the US, and they come back to India and they continue their practice. I mean, I talk about internal medicine. But I've not met anyone who did family residency and came back to India and did practice here. So
Mm.
do you see as a possibility, or have you noticed anyone, or have you met
Yeah.
anyone who came back to India and continued their practice, and how their uh, job hunt and things like that have been?
So part of it is, I think, the statistics of this. The number of people who do internal medicine residency is like a little bit higher, I would say, compared with the number of people who do family medicine residency. And actually, since 1990s, it's been kind of stagnant, a little bit up and down and up and down, but like stagnant for family medicine from international medical graduates coming in. Even though there's like a solid number, like 10-15%, they've been like just sitting there in the plateau, and we're looking into making it a little bit more of a slope right now, and that's why we need more people applying into family medicine. But if you do family medicine here, you can still practice in India as long as you have the registration and everything, the licensing. I do not personally know a lot of people who did that, because they might find what they want here and they might not come back. If that's your goal, you can. And sometimes the employers that you work with here do support it, where you're working 8 months here, 4 months in India, or 6 months here, 6 months in India. And the global health missions, the rural practice missions, and certain international projects that you want to do through the university here and connect it with India, it's like really easy to do. And that would actually serve a really good purpose for both the university in terms of their international presence, and also for you, because you could meaningfully contribute to not only people here but to people in India, the patients and community in India. I personally, in the future, I'm looking into making it like a split, but I haven't noticed anyone who has done that. And that's where kind of global health comes into picture, where you can justify taking that break and doing a project or doing work in India or practicing in India for a certain amount of time. If you want to do a full-time job in India, just do the residency here, get the training and go back to India. That's another option. You might be able to do general practice. You might be able to do hospital medicine based on which city you're going into in India. But some, like, I don't know, I think the Indian board would decide, like the medical board, the Indian Medical Association, and a couple of other entities, they would decide if you need any special certifications to do certain things back home. But I would imagine that you should have most of the opportunities open.
Yeah. Yeah, that is actually interesting because I didn't know that you could do this split between
Mm.
actually, working in a university in the US versus going for an global outreach program. That's actually very interesting
Mm.
mention.
And a lot of people, a lot of universities support it. You just have to like find the right place if you really want to do that. If you want to go back home again, I would check with what the rules are, but I'm pretty sure they would take it just as they would take internal medicine boards, because it's kind of accepted. Some of the board certifications are accepted in other parts of the world. And there is a thing called lifestyle medicine. I just wanted to add that if you get certified in lifestyle medicine in the US, right now there is a residency curriculum in FM to get double certified in lifestyle medicine and family medicine. I'm doing that. And you can basically use the lifestyle medicine as your whole practice if you wanted to. And in India, I would think there's a lot of demand for it, something like that, to like deal with all the non-communicable chronic diseases and how to use lifestyle modifications, evidence-based lifestyle modifications to like help in addition to medication management, to like help with the chronic conditions. So I'm looking into exploring that, and I think there's a lot of scope for that in India as well.
That's interesting because lifestyle medicine is becoming very popular these days. A lot of Instagram, social media influencers, they talk about lifestyle medicine, but I believe personally having certification would give you an edge over all the other people, and obviously it helps patients down the lane, not just in the hospital but outside hospital, things to take care.
Yeah.
So um, did you have any other questions, Saket? Or
No, I'm good.
nice. So
So
a
much,
lot of interesting questions today. Any other questions from other people here for today? Okay.
Most of them are covered. All about the FMS put.
Nice. Nice. So I think we can end it here for today. Just taking into time consideration, and thanks for all the insights, Dr. Denduluri. We really appreciate you giving us all the information and insights, and answering all the questions. And since we can do that Instagram takeover, we would put out a poster in next few minutes, and in the next 24 hours, whenever you have time. How this works is people will ask the questions and you can reply it over there and just type it out the answer, or you can also speak. It depends on how you want to do it. And people who are not comfortable coming up here and talking, and who are not able to attend due to the different time zones they are in, they can put up their questions there. And uh, so yeah, that would be the next thing. And we would love to have you back again sometime in the future when you're practicing as an attending, teaching other students back in Boston. So hopefully you get better soon with the cold that you have. But we really appreciate you talking with all the struggle that you had. So
Well, thank you so much for having me. It was really nice meeting all of you, and you're doing great work. So continue doing that, and it would be nice to be a part of this in the future. Thank you.
awesome.
Thank you so much.
Thank you. We'll end it here today and see you in the Instagram takeover.